If you look at the process of normal conception, for a woman to get pregnant, you need an egg, you need a sperm, and they have to meet. So at the time of ovulation, which typically happens in the middle of the cycle, say day 13, day 14 of her cycle, the egg is released from the ovary and it's picked up by the fallopian tube, and it sits at the end of the tube waiting for a sperm to approach it. During natural intercourse, the sperm is deposited in the vagina. Some of the sperms swim up into the cervical canal, into the uterine cavity, and then spread out through the fallopian tubes and go both to the left tube and to the right tube. At the end of the tube, they encounter the egg and fertilization occurs. The embryo that is formed then is transferred into the uterine cavity by the tube. The tube is just not a single tube. It has functional ability to propel the embryo into the uterine cavity. The lining of the tube has cells which have hair on them, and these cells beat in a direction towards the uterine cavity, propelling the embryo into the uterine cavity. Also, the tube contracts and relaxes in such a way that it pushes the embryo into the uterine cavity. So this all must happen for an embryo to be able to reach the uterine cavity and implant. Till the mid-1970s, if the tube was damaged and blocked, there was no way by which the egg and the sperm could meet. So gynecologists would try to resume this meeting of egg and sperm by trying to restore the patency of the fallopian tube. And towards this, lots of surgical techniques by microsurgery operating on the tube under a microscope were devised, but these weren't very successful. Very often, tubal patency could not be restored even after this extensive microsurgical procedures. Or, if the tube became patent, it still could not fulfill the functions whereby the embryo would be pushed into the uterine cavity. And there was a lot of difficulty in getting women with damaged tubes to get pregnant. This is when we started thinking of fertilizing the egg outside the body and then returning it back into the uterine cavity by a procedure called in vitro fertilization, or as it popularly became known as the test tube baby treatment. The first test tube baby was born in 1978. What we do in the test tube baby treatment is to stimulate the ovary to produce more follicles, harvest these follicles and collect the eggs, and then make the embryo in the laboratory. We then grow the embryo for 2 or 3 days and then transfer it back into the uterine cavity. I'm going to explain in detail how this procedure of IVF or test tube baby treatment is carried out. We want more eggs instead of the traditional 1 egg that a woman makes in a natural menstrual cycle. And to achieve this, we stimulate the ovary by using a series of medicines, series of injections called gonadotrophins. The treatment begins on the 2nd day of the menstrual cycle, and we start giving the lady daily injections. These injections can quite often be self-administered by using a pen. So the woman doesn't need to go to a hospital or to a clinic or to a nurse to receive the injections. She can give these injections to herself. But she does need to come in for 2 or 3 internal scans to see how the ovary is responding to the injections. We monitor the growth of the follicles by serial ultrasound scanning. And at the same time, we also measure the growth of the lining of the uterus, which we call the endometrium. We titrate the dose of the injections that the woman is to receive depending on the response from her ovaries. So for instance, if the response is slow or she is not making that many follicles, we might increase the dosage of injections that we are giving this lady. When both the follicles have reached the appropriate size and the endometrium has thickened to the right thickness, we plan the egg collection from this woman. Prior to the egg collection, we give the final trigger of HCG so that the egg is able to undergo its final maturation. And 36 hours after that HCG injection, egg collection is performed. Egg collection is a fairly simple procedure. It's done under sedation and local anesthesia. So if the woman wants to be wide awake and watching her eggs as they come out, she's welcome to do that. If she doesn't feel comfortable about this and wants to have a little nap while the procedure is going on, this too can be done. We can increase the sedation so that she is comfortable and pain-free. Through the vagina, we collect the eggs under ultrasound guidance. No cuts are required for this procedure at all. The procedure takes roughly about 30 to 40 minutes. At the end of the procedure, the woman is transferred into the recovery ward, where she recovers from the procedure over 45 minutes to an hour. She's then allowed to sit up, drink something, use the toilet, and then is ready to go home. The husband has given us a sample of semen the same morning. We've treated it in the laboratory and retrieved the best sperms from this sample. These sperms are then added to the eggs so that they are able to fertilize the eggs. The embryos that are formed are checked the next day, and then we grow these embryos in the laboratory over the next 2, 3 or 5 days. At the end of this period, we choose the best embryos and transfer them back into the uterine cavity by a very simple procedure known as embryo transfer. This does not require any sedation or anesthesia. The patient is able to see her embryos on the television screen before we transfer them into the uterine cavity and is able to leave the clinic 5 to 10 minutes after the embryo transfer. After the embryo transfer, the patient requires no special care. We encourage our patients to resume normal activities the same day, and most patients go to work the next morning. So no bed rest is required after the procedure. Some medicines may be required after the procedure, but these are simple and don't require the patient to come into the center at all. Typically, we would advise her to do a blood test 12 days after the egg collection to detect whether she has fallen pregnant or not.